Good morning, everyone, and welcome. I'm Dr. Asim Hussein, and I'm pleased to have you here today. We will be discussing endocrine and metabolic emergencies, focusing specifically on the hyperosmolar hyperglycemic state, or HHS. Over the next few slides, we'll explore what HHS is, how to recognize it, and how to manage it effectively. Let's get started. All right, let's take a closer look at this case. We have a 72-year-old man with type 2 diabetes who's presenting with confusion, severe dehydration, and lethargy. His lab results show a very high blood glucose level of 48 millimoles per liter, which is quite significant. Interestingly, his blood pH is 7.36, which is near normal, and his serum osmolality is elevated at 342 milliosmoles per kilogram. Additionally, there's a mild presence of ketones at 0.8. Now, these findings point us toward a specific diagnosis. The key features here are the extremely high glucose and serum osmolality, combined with relatively normal pH and mild ketosis. This pattern is characteristic of a hyperosmolar hyperglycemic state, or HHS. It's important to distinguish this from other diabetic emergencies like diabetic ketoacidosis, which typically involves a lower pH and more prominent ketosis. Understanding these lab values and clinical features helps us identify HHS as the most likely diagnosis in this scenario. Recognizing these patterns is crucial for timely and appropriate management, especially in older patients with type 2 diabetes. So, in summary, the combination of severe dehydration, high serum osmolality, and minimal ketosis points us toward hyperosmolar hyperglycemic state. Let's look at the correct answer here, which is B now. The key points to remember from this slide relate to the diagnostic criteria for hyperosmolar hyperglycemic state, or HHS. The hallmark features include a blood glucose level greater than 30 millimoles per liter, which indicates severe hyperglycemia. Along with that, the serum osmolality is typically over 320 milliosmoles per kilogram, reflecting significant dehydration and increased concentration of solutes in the blood. Importantly, even though blood sugar is extremely high, ketones are usually minimal or absent, which helps differentiate HHS from diabetic ketoacidosis. And lastly, the blood pH tends to be near normal, meaning there's no significant acidosis. Understanding these key lab features helps us recognize HHS quickly and distinguish it from other diabetic emergencies. Remember, the combination of very high blood sugar, elevated serum osmolality, minimal ketosis, and near-normal pH is the classic pattern we should keep in mind. Let's take a closer look at this case. We have a 68-year-old woman presenting with hyperosmolar hyperglycemic state, or HHS. Her blood pressure is 85/50, which indicates hypotension, and her heart rate is elevated at 124 beats per minute, suggesting she's tachycardic. She also has dry mucous membranes, pointing to dehydration. Her blood glucose is alarmingly high at 40 mmol per liter. Now, when approaching treatment for HHS, the first priority is to restore circulatory volume and address dehydration. Given her low blood pressure and signs of significant fluid loss, the immediate step should be fluid resuscitation. So, among the options, giving large volume IV fluids, specifically 0.9% saline, is the most appropriate initial treatment. This helps to improve blood pressure, restore perfusion, and dilute the serum glucose gradually. Starting insulin is definitely important, but it's usually given after initial volume repletion to prevent rapid shifts and other complications. Giving bicarbonate or dextrose are not first-line treatments in this scenario, and starting potassium infusion should be based on her serum potassium level, not blindly initiated. In summary, the key point here is that, for a patient presenting with HHS and signs of dehydration, the first step is to give large volume IV fluids to stabilize her condition, before moving on to insulin therapy or other interventions. All right, let's look at the correct answer here, which is B now. The key point to understand is that HHS, or hyperosmolar hyperglycemic state, is characterized by profound dehydration. This dehydration can be quite severe, often requiring the administration of fluids as the very first step in management. Typically, we're talking about replacing a deficit that can be around 3 to 6 liters, so it's a significant amount. It's important to emphasize that before starting insulin therapy, we need to focus on rehydration. Administering fluids helps restore circulatory volume and reduces serum osmolality. Only after we've initiated and begun to see a response to the fluids do we then start insulin therapy. The reason for this sequence is that starting insulin too early, before correcting the dehydration, can potentially worsen the patient's condition, possibly leading to shifts in fluid and electrolytes that could be dangerous. So, in summary, always prioritize fluids first in HHS management, and only after fluids are underway do we consider insulin therapy. This approach helps stabilize the patient safely and effectively. All right, let's look at this important question about when to start insulin in a patient with hyperglycemic hyperosmolar state, or HHS, who remains hyperglycemic after initial fluid therapy. The key point here is understanding the typical management sequence. So the question asks, when should we start insulin in this scenario? The options are immediately on arrival, only after fluid resuscitation is underway, never required, only if ketones are above 3, or when the pH drops below 7.2. Now, the most critical concept is that in HHS, our first priority is usually to correct the severe dehydration with IV fluids. Once we've started volume resuscitation and the patient's hemodynamics are stable, we then consider insulin therapy. Starting insulin immediately upon arrival isn't typically recommended because it can cause rapid shifts in fluids and electrolytes, potentially leading to complications. Similarly, insulin isn't never required. It's essential in managing hyperglycemia, but timing matters. In this case, since the patient remains hyperglycemic even after fluids, the appropriate step is to start insulin after initial fluid resuscitation has begun and the patient is stabilized. So the correct answer here is B, only after fluid resuscitation is underway. This approach ensures safety and effective management of the hyperglycemia while avoiding unnecessary risks. This concept ties back to the overall theme of managing HHS carefully, prioritizing hydration first, then using insulin to bring down glucose levels safely. All right, let's talk about the correct answer, which is B. The key point here is understanding why insulin administration is delayed until the volume is restored. When insulin is given too early, it causes a rapid decrease in blood glucose levels. This quick drop can lead to cerebral edema, which is swelling of the brain, and that can be very dangerous. So the main reason for waiting is to prevent this risk. Ensuring that the patient's volume status is corrected first helps stabilize the situation and reduces the risk of complications associated with sudden glucose drops. This approach is critical in managing these cases safely and effectively. Okay, let's walk through this question. We have a patient with hyperosmolar hyperglycemic syndrome, or HHS, and their measured sodium is 148 mmol per liter. Their glucose level, however, is quite high at 42 mmol per liter. When glucose is that elevated, it can actually cause a dilutional effect on sodium levels, making the measured sodium appear lower than it truly is. This is where the concept of corrected sodium comes in. To get an accurate picture of the patient's sodium status, we need to adjust or correct the sodium level based on the glucose level. The correction factor is typically about 1.6 mmol per liter increase in sodium for every 5.6 mmol per liter increase in glucose over normal levels. But for simplicity, many clinicians use a correction factor of 2 mmol per liter sodium for every 5.6 mmol per liter glucose above normal. In this case, since glucose is 42 mmol per liter, which is significantly higher than normal, we need to calculate the correction. The goal is to find the sodium level that better reflects the patient's actual sodium status, not just the dilutional effect caused by hyperglycemia. By doing this correction, we can better assess whether the patient truly has hypernatremia, or if it's just an artifact of their high glucose. Now, looking at the options, which one do you think matches the corrected sodium level? Alright, let's talk about how to adjust sodium levels in cases of hyperglycemia. The key point here is that, for every 5.5 mmol/L increase in glucose above normal, which is around 5.5 mmol/L, you need to add about 1.6 mmol/L of Na+. So, if a patient's glucose is significantly elevated, their serum sodium can appear artificially low due to dilution. This is why we use a correction formula. It's a way to estimate what their true sodium level should be, accounting for the high glucose. Remember, hyperglycemia causes a dilutional hyponatremia because water shifts from the intracellular to the extracellular space, diluting the sodium concentration. So, when evaluating a hyperglycemic patient, this correction helps us understand whether their sodium is truly low or if it's just an artifact of the elevated glucose. This adjustment is crucial for proper management and avoiding unnecessary treatments. The answer here is C, which reflects this correction method. Now, let's consider why it's crucial to reduce glucose levels in HHS slowly and in a controlled manner. The main reason, which aligns with the options on the slide, is to prevent serious complications. Specifically, the correct answer here is D, to avoid persistent ketosis. Rapid shifts in glucose levels can cause a sudden osmotic change, leading to cerebral edema, which can be very dangerous. When we lower glucose too quickly, it can also disrupt the body's delicate balance, resulting in other issues like hypokalemia or even arrhythmias. But the primary concern in this context is cerebral edema. This is why we always aim for a gradual reduction. It's about safety and preventing further neurological injury. In the broader scope of managing HHS, understanding this principle helps us deliver safer, more effective care by minimizing risks associated with rapid correction. So, controlling the rate of glucose reduction isn't just a procedural step. It's a critical part of preventing potentially life-threatening complications. The correct answer here is C when we look at this scenario. The key concern is the rapid osmotic shifts that can occur, particularly in cases like this. These quick shifts can lead to cerebral edema, which is a serious complication. It's important to note that this risk is similar to what we see in pediatric DKA, where rapid correction of osmolar imbalances can cause brain swelling. So, understanding the potential for rapid shifts helps us appreciate why careful management is essential to avoid these dangerous outcomes. Now, let's look at the key diagnostic features of hyperosmolar hyperglycemic state, or HHS. First, we see that glucose levels are typically very high, greater than 30 millimoles per liter. This indicates severe hyperglycemia. Next, osmolality is elevated, usually over 320 milliosmoles per kilogram, reflecting the concentrated blood due to dehydration. The blood pH tends to be above 7.3, which helps differentiate HHS from diabetic ketoacidosis, where the pH is lower. Minimal ketone production is another important point, often only 0 to 1, meaning there's little to no ketosis involved. Clinically, this condition presents with severe dehydration and altered mental status, or AMS, because of the extreme fluid loss and osmotic shifts. To sum up, these diagnostic criteria highlight the profound dehydration and hyperosmolar state characteristic of HHS, which we need to recognize early for prompt management. This slide emphasizes the importance of these specific lab findings in confirming the diagnosis and understanding the severity of the condition. Let's go over the management priorities for treating HHS. First, we focus on aggressive fluid resuscitation, starting with 0.9% saline at about 1 liter per hour initially. The main goal here is to carefully lower the osmolality, aiming for a decrease of no more than 3 mosm per kilogram per hour. This helps prevent rapid shifts that could cause cerebral edema. Once we've begun fluid replacement and initial stabilization, we consider insulin therapy. Importantly, insulin should always be administered after fluids are in place to avoid rapid shifts in serum osmolality. We typically start with a low-dose infusion, around 0.05 units per kilogram per hour. Potassium management is also crucial. We need to maintain serum potassium levels between 4 and 5 mmol per liter, because insulin can drive potassium into cells and cause hypokalemia. If blood glucose drops below 14 mmol per liter, we add dextrose to prevent hypoglycemia during correction. Remember, correction should be slow and controlled. We aim for a glucose reduction of less than 5 mmol per liter per hour, again, to avoid rapid shifts that could lead to cerebral edema. To summarize, in managing HHS, our priorities are careful fluid replacement, cautious insulin administration, vigilant potassium monitoring, and controlled glucose correction. All of these steps are vital to safely bring the patient back to a stable state and avoid complications. Now, let's take a look at some of the potential complications associated with HHS. One of the main concerns is venous thromboembolism, or VTE. Patients with HHS are at high risk for clots, so in these cases, prophylactic use of low molecular weight heparin, or LMWH, is actually mandatory to prevent that. Other complications include cerebral edema, which, although less common, can be life-threatening if it occurs. Rhabdomyolysis is another concern. This is when muscle tissue breaks down rapidly, potentially leading to kidney damage. Speaking of the kidneys, renal failure is also a serious complication that we need to be vigilant about. To sum up, while HHS is primarily characterized by extreme hyperglycemia and dehydration, these complications remind us that it can rapidly become a life-threatening condition if not managed promptly and carefully. Thank you so much for taking the time to be here today. I really appreciate your attention and engagement throughout this presentation. I hope the information shared has been helpful and insightful for you. Remember, the key points we discussed are not just ideas in theory. They have real-world applications that can make a difference. I encourage you to take these concepts and consider how they can be integrated into your own work or projects. Again, thank you for your interest and your participation. I look forward to seeing how you apply what you've learned. Have a great day.